All right, a real quick review on basic pharmacology is things, concepts that you were supposed to be proficient in before you move forward in A&T, okay? Basically, my whole stance on pharmacology, on medications, I've told you before, is that you need to know why you're given a med, and you need to know what's going on inside the body when you give that med. Now, certainly you're not expecting you to know these drugs on a pharmacist level, all right? But I don't think that it is too much to ask of you to understand the receptor site theories and how these different drugs affect the different chemicals in the body and things like that. Simply for the fact that a lot of the drugs that we're going to talk about, you may see more in a home environment than you may see in an emergency environment. But a lot of the drugs that you're going to give in the emergency environment, they could have some pretty serious adverse reactions or some pretty serious side effects. And so you need to know exactly why you're wanting to give those drugs. There's a couple of things that you've got to remember when you give a medication. Obviously, you need to know the things that I just spoke about. You need to know your precautions, your contraindications, things like that. Yeah, that seems like a lot to remember, but you're taking on a big responsibility, okay? You're taking on a role of autonomy out in the field. When you work out in the field as a paramedic, yes, you've got your standing orders, and yes, you've got the ability to call the doctor. However, you are purposed to know this stuff. Your purpose should be to know this stuff, to know what you're going to give, to know that when you see this, you know that I give this medication because this is how the medication works. You also need to know proper techniques. And to further that a little bit, you need to know which ways you can give medications. Is this a medication that's IV only? Is this a medication that's IM, IV? Is this a medication that you can give inhalation only? Is this a medication that you can only give sub-Q or IM? Okay? There's not a ton of medications or let me backtrack a little bit. On your medications, there's not going to be a ton of differences in the routes that you give, all right? And a lot of it's going to be pretty self-explanatory. You've got your nitro tabs. That's going to be a sublingual. We know that. You got your aspirin. That's going to be a PO. All right? You know that you give morphine, IV. You know that you will give your cardiac arrest medications, your ACLS medications. You will give those IV. All right? You know that in some situations you'll give epinephrine, IM or sub-Q, depending on the patient. All right? But you're going to know more medications than you did in A&T. You're going to know higher dosages, higher concentrations. You need to know that kind of stuff. For instance, you're going to be learning to give epinephrine by IV. But you're going to be given epinephrine 1 to 10,000 by IV. Epinephrine IM or sub-Q is 1 to 1,000. So if I slip up and I draw up epinephrine 1 to 1,000 and give it IV, then I've just made a pretty critical error, all right? Because I've just given a very high concentration of epinephrine through the IV. Drugs will change as far as dosages go, as far as indications. I've mentioned it before, the basis of any type of health science is the science behind it. The basis of EMS, the basis of nursing, the basis of anything that has to do with health science is the science. And the science doesn't lie. So they're constantly doing research. They're constantly doing evidence-based practice. And so what you learn today may change a little bit in the future. You've got to be up to date on your medications, all right? For instance, up until about 2 months ago, vasopressin was given in all cardiac arrest. Or at least it was an option to be given in cardiac arrest. Well, 2 months ago, the science says, you know, there's really not a whole lot of difference in epinephrine and vasopressin. We haven't really seen that one's better than the other, so let's just limit the confusion. We're going to pull the vasopressin off, just leave epinephrine, because that's what mainly everybody's given, that's what everybody's used to. All right, so not a big deal unless we work a cardiac arrest. And we have vasopressin on there, and we give vasopressin. And we document that we give vasopressin. And this patient eventually dies, and you giving vasopressin probably had nothing to do with them dying. But that lawyer is going to look for any discrepancy in your PCR, anything that you could have done that could have facilitated the mortality of that patient. Does that make sense? You see what I'm saying? So it's very important that you stay up to date on not only protocols, but national changes in medications and things like that. All right? Of course, we're always going to have references available. You need to have a reference available. One of my favorite things that I did when I was in nursing school and working on the ambulance was when I would take a transfer. I didn't have a fancy smartphone. It was only 6 years ago, but I didn't have a fancy smartphone back then. I had a little pocket drug guide. When I take a transfer, I pull out the patient's drug list, and I would look up each one of those medications just so that I'd further familiarize myself with them. It's constantly an expanding knowledge, all right? It's just like I told you with cardiology and strip recognition and management and stuff. It's repetition, repetition, repetition. Learning these drugs, learning how they work. That's why it's so important that you know how the body works normally, so that you know how these drugs would react to the body, okay? So you've got your 6 rights of medication. Jeez Louise.
He was on that siren. PTS, it's not fire department.
So, 6 rights. Your right medication, your right dose, your right time, your right route, your right patient, and your right documentation. If you have those 6 rights and then you've asked for allergies, then you're usually going to be okay when you administer a medication. All right? I might add that you might want to consider the right indication. The right indication. I may have a patient that would be a candidate for several different types of medication, but then as I further their history, I see. Let me take one for example. One that I was having a discussion with Lee about yesterday. Lasix. All right. So I've got a patient that's in CHF. All right. He's having CHF. He's in pulmonary edema, flash pulmonary edema. He can't breathe very well. We've tried CPAP. He can't take the CPAP. All right. So we know that when we hear fluid in the lungs, we want to do what? Pull the fluids off, right? We want to pull the fluids off. So one of the drugs that we'll have in our drug box is a Cat B, a Category B drug that we have to call. We know that we've got an indication that we need to give Lasix, a diuretic. However, upon further examination and further history, we find out this patient is a renal patient. He goes to dialysis 3 times a week. He already has issues with electrolyte imbalances, so I had the right indication, but upon further history, I don't have indications. I've got contraindications now. All right? You've always got to get a good history, get a good assessment on your patients with these drugs. Now, I found this. Patients do drugs round the day. This may be something that helps you with your rights of medication. Patients do drugs round the day. The right patient, the right drug, the right dose, route, time, and documentation. All right. When you other special considerations upon giving medications, and especially ones that you may run into ethical dilemmas with: pregnant patients, lactating patients, pediatric patients, and geriatric patients. Somebody explained to me an ethical dilemma you may be faced with a pregnant patient. What could? Medication. The medication could. All right. It may be what? What's that word? That T word? Yeah. Tetragenic, teratogenic is a T word that means that it's going to be harmful, and there's different levels of harm based on lab trials and studies on it. So that in itself may be an ethical dilemma. But let me just expand it and make it a little more personal. You've got a patient. She is pregnant. She is 8 months pregnant. And she is in a fatal arrhythmia. So you've got an almost full-term baby, and let's just say you've got a medication that's in your hand that you know could either kill the baby, or it could cause some serious defects, but it would save the mother's life. What route do you go? No, you don't have to call medical control. I mean, of course you'd want to call medical control, but this is a decision that let's say that you don't have time to make that decision to call medical control. You got that decision to give the med. What do you do?
The mother dies, the baby dies.
That's right. That's right. If the mother dies, the baby dies. All right. You see TV shows. I forgot what show it was. It was House or something like that, where the mom was refusing to take the medication because it would ultimately really harm the baby and all that. And that is her right to choose to do that in the right setting, where if she were to go, they could keep her alive as an incubator for that baby. Okay, that is her right to choose that. And that's even her right to choose that in the field, to a degree. But you got to remember, no matter what your stance on all the political agendas that are going on right now, you got a living heartbeat inside of that lady's body. Another baby or another human being inside of that body. All right? So you do have tough decisions to make. And hopefully you won't ever have to make those decisions. But you've got to remember that a dead mother is going to equal a dead baby across the board. All right? That's one of the special considerations. All right? Also, you've got to remember that sometimes the normal drug dosages may not work in a mother who has changes in fluid balance, who has changes in blood pressure, who has changes in different aspects of anatomy and physiology. Okay, your pregnancy categories, you should have seen these before. Most of our drugs are not going to fall anywhere where there is severe fetal risk or fetal demise. All right, most of our drugs that we give. If there is a question, Kyle was right. If you've got time, if there is a question about it, let's call. Let's find out, all right? But never, ever withhold care from the mother if it's a life or death situation. All right? Other considerations, your pediatric patients. How do we determine what dosages to give pediatric patients? All right? How do we determine what dosages to give medications to pediatric patients? You're right, but not completely. Weight-based. Most of our dosages for pediatric patients are weight-based. Because you've got to remember several things. Metabolism in a child. Body surface area in a child. Circulating volume in the child. The development of organs in the child. There's a lot of things that work against the child when you give medications. A lot of situations with children, you have to give meds more frequently because they metabolize quicker. It's smaller dosages, but your big deal here is that you want to minimize the risk of toxicity. Now, one of the areas as EMS providers that we fail in consistently is pediatric care. Why is that? Why do you think that is? Because you don't deal with pediatrics that much. You don't deal with pediatrics that much. But how fair is it to that one pediatric patient that you will get called to this year that, hey, we don't deal with them that much, so we don't keep up to date. We don't study it out. We don't seek continuing education for pediatric patients. It's not. All right? So there's definitely ways that they're trying to address these issues with pediatric care, but most importantly is that you need to have a baseline idea of your medications that you can give to children and your dosages. The Braslo tape, that is a pretty useful tool. Now remember, each patient is different, so a Braslo tape is based off of a normal body surface area, a normal height, and all that. You know, you may have that kid that's 4 feet tall and 150 pounds. All right, so you still got to use your judgment there. All right, and if you don't feel comfortable enough in your judgment, then you need to be sure that you're online with the doctor. Okay, and then geriatric patients. Several things with geriatric patients that you have to look out for. One of the issues is polypharmacy. What do I mean by polypharmacy? Not multiple pharmacies, but multiple medications. Multiple medications. Now, this sometimes can be very, very harmful to the patient because of the use of multiple doctors, multiple specialists. Nothing against doctors in their offices, but these doctors are often seeing 30, 40, 50 patients a day. So sometimes these medications may go by the wayside, that the renal doctor prescribed this med and the cardiac doctor prescribed this med, and you know, I don't know, the other doctor prescribed this med. And so I think they're getting better about it. I think the pharmacies do a good job of looking at these contraindications and these, you know, how the meds work. But an older person who is chronically ill, who has to take several different medications, you got to think of it like this. They've got a constant homeostatic balance fight going on inside of their body. They've got this med that's acting on these receptors, and this med that's blocking this chemical, and this med that's speeding up this, and this med that's slowing down this. And so it's a constant battle back and forth. And so oftentimes these patients have they have a tough time with the metabolism of it. Also, as they age, their body systems slow down. All right, so metabolism slows. Another big issue, and it's not with all right? So just like dementia is oftentimes a symptom that is mainly seen in aging, but is not a symptom of aging. Does that make sense? Doesn't mean that every old person or every elderly person is going to be demented or senile. Just means that this is common that we see in that age. We need to be checking and making sure that their memory. Did they take their meds today? Do they have somebody helping them take their medications? Do they have their list of medications? All right. Sometimes some of your issues, plain and simply, come from the patient forgot they took their medicine at 6 o'clock, then took their beta blocker again at 8 o'clock. So now they've got a double dose of beta blockers, and what's going to happen? Pressure's going to bottom out. Heart rate may fall. All right. So you know, certainly that's special considerations there. We don't have a Broslow tape here. I want to get one. The ones that we have are outdated, but we're waiting until American Heart. They've published their stuff, but we're waiting for everybody to catch up with them. But we've got a Broslow wheel as well that you can get a weight and you can turn it, and it'll show you that stuff. I should have brought it up here. I don't think I've got one up here. Really quickly, pharmacokinetics and pharmacodynamics. Pharmacokinetics are how the drugs are transported into and out of the body. So that's going to be how we give it and how it's transported to the target tissues. Pharmacodynamics is how they affect the target tissues or the target cells. Now, one thing that I always mention when we talk about drugs is that, yes, when we give medications, we have target tissues. We have target tissues. For instance, one of the more drastic ones, you've got your clot busters, all right? Your anticoagulant medications that are designed to go in and to break up the clot that's in the coronary artery or in a cerebral artery. So that is the target tissue. But what is something that you have to be careful on with any patient that's on an anticoagulant therapy? Bleeding across the board, because systemically it will affect the clotting processes of the whole body. Even though you've got your target tissues, it will still affect the whole body. So remember that these medications will be kept in the closed container until they hit the target tissues, and then they will be released, but not only to those, oftentimes they are released to the other cells as well. Does that make sense? That's why you've got to be extra careful when you give these meds and understand the overall systemic effects of them, all right? Now, again, this is a review, so I'm not going over it all. Just going to mention it just so that you've got it in your mind again. With your pharmacokinetics, you've got your processes of absorption, distribution, biotransformation, and elimination. So absorption. How is it being absorbed into the body? How is it being made available? Then once it is brought into the body, how is it being distributed to the body? Does this medication, is it in a molecular form or a chemical form that cannot be used by the body? Does it have to go through the process of biotransformation? And then once we go through all these steps and it's been used, the metabolite has been used and we've got the leftover, how does it get rid of it? How is it released through the body? All right? So, for the most part, these medications are going to be in liquid form, molecular form. So most often it'll be through the processes of the water movement, the fluid movement. You do have some meds that you will give in the gaseous form, right? All right? There are some drugs that aren't soluble in water. I don't think there's really any that we give that aren't soluble. We did give lipid emulsions when I was working in the hospital that were lipids and they weren't soluble in water, and so you had to be extra careful with those and use a certain filter and things like that. Very rarely will you have anything like that unless you're on a long distance transfer. All right? The ion transport this is just a generic channel protein, but it's the same process as the sodium-potassium pump or a calcium channel or any other protein channels, all right? So you have to have what to open it and close it? ATP or energy. You got to have energy to open and close it. So medications depend on energy. The area of the body, the surface area of the body, that has a lot to do with the rate of absorption. All right. Let's see, what else we got? We got bioavailability and distribution. So bioavailability, the measure of the amount of drug that's still active after it reaches the target tissue. So you can kind of think of bioavailability as the medication form of dead airspace. Remember when we talked about respirations? When we deliver tidal volume, we've got that dead airspace, so that 150 milliliters of air that's not being used. All right? So bioavailability means that I'm going to give this medication in this amount of dosage, but after it goes through all the steps of the pharmacokinetics, there's only going to be a certain amount that's left over for the target tissue of that metabolite that's going to be available for the target tissue. That's why in a lot of medications you have to provide what's called the loading dose. So you've got to load the body with that medication. Then you do maintenance dosages after that. That's why you have time frames that you give medications. It all has to do with half-life. What's half-life? All right, so the time it takes for the body to metabolize half of the medication, all right? We want to keep medications at therapeutic dosages. That's why you look at your patient, and if you've got a time frame, you can give this amount of drug every 3 to 5 minutes. If I've given this drug and it's had an action, if it's worked, or it's starting to work, or even if it hasn't worked yet, I still want to give that medication again. Now, if I give that medication and I have adverse reactions, or if I have anaphylactic reactions, certainly I pull it away. All right, but that's why you've got these times, because you want to keep the medication in therapeutic dosages. All right, it's a lot easier to keep it up than to allow the half-life to occur and then the rest of it to be metabolized out, and then we have to load them again. Anybody in here ever had surgery and been in the hospital for a little while? I have. After you have surgery, or if you're receiving pain medications, what does that nurse tell you as far as the pain medications go and receiving the pain medications? Don't wait until you're in severe pain to ask for your pain medication, right? Is that what they ask? If you had a good nurse, that's what they told you. All right, that's what I always told them. I loved giving pain meds because that meant that My patient's got to rest. And so I would always say don't wait until you are just in excruciating pain to ask for your pain medication. And in most situations, if I knew that it was a rather large surgery or a rather large injury or something like that that would have excruciating pain associated with it, I would follow a schedule of pain medication administration. And that's simply for the fact that you want to keep those therapeutic levels up. You don't want to give enough that it sedates them or anything like that, but you want to keep those you want to keep those levels up just so that the therapeutic levels are there. All right. And again, the distribution and the bioavailability, that's one of the aspects that's going to affect geriatric patients. All right. The body likes its numbers, even when we give meds, and certain certain pathologies, acidity, alkalinity, the pH of the body, that can affect the way that the medication, the metabolite, is transported across the through the body. Now, one of the things that we talked about again in airway was we were talking about the protein of hemoglobin and how a low pH or a high pH would affect the availability of the oxygen to be carried or to be absorbed by the hemoglobin in the cell. And it's sort of the same way here, all right? I think we're okay there. Saw that. Biotransformation, it gets pretty technical, pretty deep, and I'm not really concerned that you know which drugs are prodrugs and which drugs are going to be biotransformed, other than the fact that you need to know which drugs are going to have a little bit longer onset, and that's because they are being biotransformed or they are being metabolized in the body. Example, you've got a patient with a blood sugar of 16. You've got two choices here, right? The first choice is to give D50, or your second choice is to give glucagon. Y'all wake up, I know operations is just so boring, just so boring.
It's just great.
But we know that pharmacology is amazing, right? All right, so we tried to give D50, but D50 we weren't able to give because we didn't have a IV access. So we've elected to give glucagon. If we were able to give the D50, it is a what? Carbohydrate, right? That's available, readily available. Then it's going to go in and it's going to work within minutes. Whereas if we choose to give the glucagon, it's actually got to go through the processes of conversion, right? And so it takes a little while for it to be metabolized. All right? So that's pretty much what I want you to know there, is just in the fact that when it comes to bioavailability, biotransformation, all that these drugs may take a moment to be active. All right? And then elimination are usually through the urine. Some can be pooped out, and then sometimes you breathe them out. Okay? Let's move forward a little bit. As far as routes go, you should know your parenteral routes and your enteral routes. Parenteral routes means what? Anything but what? Any route other than being digested. All right? Any route that goes anywhere other than the GI tract. All right? Come on, guys. Now wake up, wake up, wake up. Get with me. If y'all need to stand up, stand up. Any route that's got to be anything other than digested. All right? So enteral is going to go into the body, into the stomach. All right? Starts with an E. You eat. You eat stuff that gets into your guts, your stomach. All right? How did I get there? All right. So your parenteral routes. You should be pretty well efficient in all of these except umbilical. We're not going to access an umbilical cord. All right. Even inhalation, topical, transdermal. Let me ask you a question. Sublingual. Enteral or parenteral? Parenteral. It's parenteral, right? Everybody agree? Yes, Nick. Why? Because it's right. It's being absorbed into the circulatory system. It's not being digested. All right. Your drug forms. Geez Louise, you should know these. This is carbon copy from AMT. Your book. That part. Carbon copy. All right. The only really the only suspension that I could think of that we've really ever given was activated charcoal, and it's not even been it's not even on our protocol list anymore. All right. Let's see. So your actions of your drugs, your mechanisms of actions, how do they get to where they need to go, and then how do they work? Well, there's a couple of different ways that they work. You've got receptor site binding, all right, such as the case as beta blockers or even agonists, okay? They have to do with the receptor site. Some of them change the physical properties of the cells. Some of them chemically combine. All right? Most of our drugs that we're going to give, they bind to some kind of receptor. Another term here, affinity. You should know this term, affinity, because we've talked about affinity with carbon monoxide has a greater affinity for hemoglobin, right? Or Narcan has a greater affinity for an opiate receptor site than the opiate or the opioid, okay? Efficacy. This is how you get a drug out in the field. This is how you get a drug to go through to pass research. Is its efficacy. Does it achieve the expected response? Now there's a lot more that goes into it, but ultimately when we give a drug, we want to know that it has a good efficacy. All right? Let's see. This is just brutal here. Terms that you're going to use a lot coming up with the meds we're going to talk about. Agonist, antagonist. You've also got, agonist, antagonist. Yes, they may do both, depending on dosages or depending on why they're or how they're administered. All right. Receptor-mediated drugs, they work like a lock and a key. All right. So your receptor is your lock. The agonist is the key. So it's the same shape as the other chemicals that would be attaching to the cell wall. But it's one that we're giving, and so it locks onto that receptor, okay? So this is just an example of it. So an agonist will fit the key, all right? So a or sympathetic agonist, it will fit the key. The cell will read it as the key, and the cell will work just like the key would have made it work, all right? An antagonist is not going to be the shape of the key, but what it's going to do is it's just going to block the whole receptor site. Nuh-uh, you can't get in here. All right, you can't get in here. So it's just going to block the receptor site, and so you're not going to have any effects of it. All right, and so whatever that receptor site was doing, you're going to start seeing a decrease in it. Okay? Let's see. Adverse responses to drugs. So certainly things that we want to be looking for. Allergic reactions, for sure. Do know the difference in a side effect and an allergic reaction. All right? Idiosyncrasy. Idiosyncrasy. Idiosyncrasy is, if I'm not mistaken, is where you have a drug that you've got this really, really weird side effect that's never been seen before. This patient just received atropine and now they're turning green. Their skin's turning green or something just really, really weird or really or different. All right. And there are some situations where a patient will tell you, oh, I can't take that medication because it makes me do this. All right, so it just may be that type of reaction in that patient. Doesn't mean that they're allergic. It's just the way that their body responds to that medication. Okay. I'm not going through all these definitions here because I'm essentially just reading the textbook to you, and I want to get on to the cardiology drugs. All right. So this is definitely things that we've talked about before, or you talked about before. Now, another one that I want to talk about, because there will be a medication that you may give one day called digoxin that's got a very narrow therapeutic index. All right. So your therapeutic index is essentially, let's just say you've got a drug that you give 2 to 4 milligrams. So 2 milligrams and 4 milligrams. All right, your therapeutic index is anything in between here is what's going to be therapy. All right, therapeutic. Anything below here has not been proven to be therapeutic to that patient. All right, and in a lot of drugs, anything to this way could be potentially harmful, if not fatal, to that patient in those dosages. Okay. Now, of course, these are going to be dosage levels in the body as well. All right. We talked about half-life. Other factors, we've talked about a lot of this stuff: age, size, men versus women, genetics. All right. Okay, that was just a real quick review, and I don't feel like it was a